So we're excited for our first episode of our new podcast, where our goal is to empower people to learn and know more about their health in this crazy, ever-evolving landscape. There's a really big gap between the quality of medicine that exists out there and that which you will get from your sort of standard of care, run of the mill. Wait 6 months to see your doctor, have a 2-minute consult, and then they kick you out the door.
Yeah, I think the goal of this series of talks is also that what we realize is that when we sit down with our patients, and we have long meetings with our patients, from 1 hour for our new patients and 30 45 minutes with our existing patients, that even then there's not enough time to go through the nuance of why we are choosing things. And so we gain their trust and we get them to understand these testing. But as you'll see today, the deep layer of discussion around each of these tests is very thought out, intentionally chosen, and not just clicked a panel for a reason. We do these things and push because we believe there's a different way to practice medicine, and that medicine can now be synonymous with health and not disease management. So our goal is to inform you, help you understand why we do this, so that we can have this hour-long discussion today that we would have with everyone. And if I had the time, I would have it with each of you. But I'd rather you have that background so that when you understand and you hear me advocating for these tests, even in someone who doesn't feel like they're at risk, you'll understand why. And you'll understand some of the background behind this, and not just that it's, us choosing, the newest, flashiest thing. It has very much evidence support, as Dr. Maloney pointed out there, and you'll see that today.
I know you and I talked about this a lot. No better place to start than heart disease. Not only is it the number one killer and a huge load on the healthcare system, it's something that we see in movies all the time, right? The sort of keeling over heart attack. And as opposed to many other things in medicine, it's something that we all know is serious. And I think most people would want to do everything they can to sort of lower their risk. Why don't you start by covering how we usually would risk stratify a patient? And let's start by comparing that to the sort of standard of care.
Yeah, and I think just to go back to your point real quick on the presentation and the leading cause of death. Sadly, everyone thinks of do I have heart disease, and they're looking for symptoms, right? It's like, do I have chest pain? I've heard of having leg swelling or shortness of breath, and is that my equivalent of heart disease? Right now, still, the leading presenting symptom of heart disease is actually sudden cardiac death. It's not chest pain. It's not arrhythmia. It's just like dropping dead, which we've heard of. And I think this is, we don't know what to do with that as a society, because it's like, well, if the absence of symptoms is the definition of the disease, well, then who are we going to screen? And that's where right now the answer is, well, we're going to risk stratify by, certain things. And meanwhile, we just define the fact that this happens in individuals with no symptoms. So we can start there. And then I think, to your point, right now, what do we do in the system? Well, right now it's a risk stratification based on your family history, and your some blood tests that many of you are familiar with, like your cholesterol panel, that puts you in a risk strategy category. And then from there, without symptoms, okay, our system recommends managing those risk factors like metabolic disease, diabetes, blood pressure, and cholesterol, and then saying that's it. So it's a very population algorithmic based kind of approach, and it says, here you go, like your risks are low, medium, or high. Here's what we recommend you doing. And then the question is to follow up on the follow up there is, well, then what's different? What are we talking about that's different? Well, that answer doesn't tell the patient in front of me how much they are at risk, and if they already have disease present. We've talked about this process of heart disease develops decades before it manifests into symptoms or disease, and they've shown this by sadly looking at autopsy reports of someone who dies in a car accident or a gunshot wound, that 20 and 30-year-olds have early heart disease, right? So they know it's starting decades before. Interestingly, not every one of them does. So now we're coming into this nuance of well, how do we figure that out? And I think that's where, with newer tests, newer cutting edge, state of the art diagnostics in both, three families, if you will, structure, we call it, like the heart structure itself, like looking at your heart in a way that is way more depth of your personalized risk. Imaging studies that are looking at your coronary arteries, the arteries that feed your heart, its oxygen supply, without having to go through an at-risk catheterization. And we get to visualize those vessels using AI-informed analytics of that visual that shows the presence of the plaque, and we'll go into that detail in a little bit. There's also functional settings. So when's the last time that your doctor like put you through not a stress test on a treadmill, with like minimal exertion if you're a fit athlete, but like actually takes you to failure on a bike or a treadmill? Like that's a different level of assessment. So less provocative testing, we call it, or we are pushing your heart to the utmost, functional status. And then there's new biomarkers. Biomarkers are just blood tests that are in our system that can tell us that the presence of inflammation and the actually signs of clots being laid down in our system actively, as opposed to just like, what's your cholesterol? It's like, what's happening to you right now that you can change next month, and we can track those changes if they're abnormal. So now we get a much more nuanced picture. And then you're like, well, Evan's going to be like, the next question is, well, why aren't we doing this all the time? Well, and therein lies the challenge.
It's a great question. Yeah, right. And when we think about heart disease, it's everybody wants to know what's going to kill me. Oh, heart attack. Okay, how can I make sure that I do not have a heart attack, right? It's really worth briefly looking at how the traditional medical system makes the decision about whether or not you are indeed at risk. Before even determining that, the main thing is that they generally wait till you have a heart attack and then they get in there and they try to do something, right? But if you tell your doctor, hey, I want to do everything I can to prevent that from happening, well, the most sophisticated algorithm for determining that is basically an extrapolation of common sense. It's called the ASCVD score. I remember learning it in med school and thinking it was a really big deal, but it really is just common sense. And it's a bunch of questions. It's, do you have diabetes? Do you smoke? Is your cholesterol super high, and are you old? Oh, and do you have high blood pressure? Right. And if the answer is yes to a bunch of those questions, we say, hey, you probably are going to have a heart attack at some point. We should do something about it. Let's try this cholesterol pill that may or may not work. Okay, that sounds good. And so how long do I take that? When do we assess whether or not it's reducing my risk? Oh, no, you just take that now for the rest of your life. And we hope it works, right? So that's the current system, which is crazy because you had mentioned imaging. You can imagine that once we've determined that you might be at an increased risk of having a heart attack, well, let's actually take a look at your heart itself and see whether you have early formation of plaques, right? Let's take a look at your blood markers and see whether or not you have an elevation, not just of cholesterol, but of other things that may lead to heart attacks in the future. Right now, there's this tremendous gap between what can be done, what should be done, and what is done, which is just kind of a spray and pray. Take this pill. We'll see you when you have a heart attack 20 years
I like
from
that.
now.
Yeah, exactly. Spray and pray. And then you've heard, and people have heard this, right? They've heard like put statins in the water, right? It's like, oh,
exactly.
Well, just minimize everyone's risk, collectively, and that'll help the world out.
Keep in mind, these meds they're among the highest side effect risk profile of any meds that exist. And now, don't get me wrong, they can be very effective, especially in particular patients, which we'll get into in a second. But yeah, the point is the current system, this is the case with a lot of parts of health, but they're basically just going to wait till you have a heart attack. So let's move into what you can do before you have a heart attack. And, what are the other ways we determine whether or not you're at an increased risk other than do you smoke? So why don't you go into that?
Well, and I think, and just to touch on one thing that you said there on even the system itself having no answer for some of these questions, the numbers coming out of these epidemiologic studies, which are just studies of the populations and different cohorts, whether it's country based or location based or type of patient based, but around 45 to 48% of patients in different studies have shown to have coronary disease with normal cholesterol. Okay, so let's just put that out there because like the thing that everyone hears about is like, oh, my cholesterol's fine, or I'm on a statin and now it's fine. Either scenario, very different questions, but let's just say your cholesterol is normal for whatever you got there. You are now in a category, great, of almost half the people having heart disease. So now you're like, well, wait a minute, what do I do now? And so now it's like that's the question that doesn't get answered, right? And that there's
Totally.
no offering given, and they're just kind of like, oh yeah, bad luck. I mean, and the argument, the answer, in our perspective, as we've seen, or with our patients, no, it's not bad luck. It's just not looking under the right stones. And so some of the ways, let's just dive into some of those ways that we're doing this. But family history is important, and that's something that your typical doctor will take into account. But just so put that into perspective, we are very aggressive on that because any family history of cardiovascular disease. When we say vascular, that means also strokes. So strokes is just like a heart attack of the brain, right? It's the same vascular process, just in the brain, not in the heart. But those processes in your family, that tells you that maybe there's something happening that's developing that. So that's a family history that matters. There are genetic factors that put someone at higher risk for this that are, we're not going to go into the details of what those are, but they are necessary to paint the total picture. So genetics are important in this picture. But kind of like taking where technology is really exciting, and everyone's, we'll start with the imaging because I think that's the easiest thing that people can put their hands around. Many people have had or been referred to or heard of, at least, the calcium score. Now, the calcium score is a CAT scan taken of the heart. It looks at those what's called the coronary vessels, or the blood vessels to the heart muscle itself that gives the heart muscle its oxygen. And it says, is there calcium present? And the assumption there is the typical training that you and I had, which is heart disease is a gradual process over the years, and by the time you're 70 or 80, it has now occluded that vessel and caused this,
Right. Those vessels get clogged up with cholesterol-based plaques that have a lot of calcium in them, and therefore you can see them on this scan.
Correct. And so that quantification does have science. And the more calcium there is, the higher risk you have of having a condition. Does everyone with a high calcium score have a heart attack? No. But does everyone that smokes have lung cancer? No. But it just increases your risk. So we know that that's a real thing. However, it misses many things. And so the analogy we'll often use, and there's a visual we can maybe cut in here and add in there, but there's this beautiful idea of kind of like the analogy I use with my patients all the time is imagine I told you there's a car broken down on the 101. The 101 in California here is like our thoroughfare of artery through, connecting the entire area. And if that car is broken down, if it's in the middle lane of a 6-lane, the middle of 6 lanes, like that's going to cause a huge traffic jam. If it's on the side of the road, people didn't even know it was there. They didn't know it was broken down. So if you imagine that car represents calcium, that same calcium's location matters immensely. But yet that is not quantified on any of these scores. So I can't tell you if your calcium is actually causing stenosis or narrowing of that artery, or if it's just out of the way and it's a patch job that was done from an injury and you're fine. We don't know that. Yes, the numbers support that you don't want a lot of calcium. We know that. Okay, I'm not arguing that. It's just more of there's nuance now, and that nuance comes in these newer studies. And for those patients that are, had these with us or we talk about them, the Cleerly study is essentially a CT angiography or a CAT scan of the blood vessels, the angiography, using AI-informed tools that then, with a radiologist that kind of, overinterprets these with those tools to look at and quantify several things, not just the calcium, but where that calcium is. Is it inside the vessel or outside the vessel? But now, and this is the game changer, the soft plaque. And the soft plaque is what we know out now causes these conditions that result in these sudden cardiac deaths in younger individuals. Some people that wouldn't expect to have it or can have quote unquote clean coronaries, empty coronaries, where that soft plaque had been developed. Imagine it like a gooey, mass that moves and blocks it, and then your body tries its best to break that down. It's not calcium, it's not calcified, it's not hard, but it did its job and blocked the flow. That we can now quantify. And so the difference there is profound because I can have it because to your point, when we have taken an individual and say, well, what is actually your risk? I can say over the last 20, 30, 40 years of your life, all of the decisions, the the good and the bad behaviors, they've manifested in something on the vessel. And we can quantify that something and say, yes, your cholesterol has been high or low, but here's your numbers right now. And I will tell you, This has changed my entire understanding of cardiovascular disease because I've imaged people who had low risk in their 40s and found immense disease that I didn't expect. And I've imaged people that had high risk. And I say high risk, I'm not talking like their LDL or their HD, their total cholesterol was 201. I'm saying their LP little a, which we know is a factor, which we'll talk about, and their ApoB was high. And I'm like, I was terrified what I was going to find. And they're 72 years old and they're like, should I start a statin? I've been trying to avoid them my whole life. And I scan them and it's literally, it looks like a 20-year-old's heart. And I was like, I don't know what you're doing right, but it's working and you can decide, but we can make an informed decision on your risk stratification. Because right now you starting a statin doesn't make any sense to me. Just
Totally.
and so that personalization is what's missing. That's what we don't have right now.
Absolutely. And that I'm glad you brought up personalization. The way in my mind I think about and I talk to my friends and family members about the evolving sort of landscape in medicine, I'll kind of run through it with cardiac risk is like this. We used to, and a lot of places still do, stratify your risk based on very generic categories, very generic, right? We say, from a population standpoint, people who generally have these features are at an increased risk. So that's age, smoking, blood pressure, diabetes, et cetera, right? Okay, we test your cholesterol. The next step would be, well, let's dive a little bit deeper. So we know people with high cholesterol, generally, we know now that there are subtypes of cholesterol. There are many more advanced blood tests that we can use to decide whether or not you are indeed at risk. The next step is we say, okay, well, let's forget about risk. Do I currently have heart disease? We don't need to wait and think about risk factors. Let's actually take a look. That's the coronary calcium scan. Where you and I are at is we know that there's an even better test because the coronary calcium scan says, to your point, is the car on the side of the road, the middle of the road? It doesn't delineate between the two. So it still is actually a risk stratification tool in and of itself. And so when you see that, even though you may not be at risk, you and I, through our clinical experience, and many studies do flesh this out to be true, even though you may not be at risk from a population standpoint, we need to actually take a look in there to see what is going on. And that's where the Cleerly study comes in. It's like we actually take a look at whether or not you are currently having and developing heart disease. We didn't talk too much about blood or genetics, but I think it is important because imaging is useful, but it is extremely beneficial when it's combined with all those blood tests. And I don't hear people talking too much about these things online. So you mentioned genetics, you mentioned blood tests. For people listening who want to take this seriously, they probably don't have a functional medicine doctor around them, right? But they want to bring all this information with them to their doctor, ask them to order these tests, and hopefully interpret the results. Why don't you run through kind of like what a good little list to bring to your doctor would be for tests that you can run to better stratify you for heart disease?
Absolutely. And I think, these factors, we will later address what to do with them. A lot of times you'll hear criticism, and I'm prepping people for this because doctors that push back or are reticent to send these tests are essentially saying, and it's a fair question to say, which is a fair statement to make, which is, if it's not going to change my practice, my recommendations aren't going to change, why would I send this test for you?
Absolutely.
Right? And that's why sometimes you have to find different providers just because they have different mindsets. And if they're like, I'm still going to recommend the same statin I recommended to you 20 minutes ago, no matter what the result is, that's a fair point on their end, but that means you have to find somebody who is actually willing to work with you. And to that note, these markers are dynamic. And so what I don't want you, and we don't advocate for you to get a CAT scan of your heart like more than we need to, because it is radiation. But we also recognize that the impact of knowing that is is necessary evil, so to speak, to handle. We can work with you on how to time those things appropriately. But the way that we track that is by looking at some of these markers that are a little bit more sensitive to that. And so for those that have seen this and heard about many of these things, there are panels right now and tests that sadly are represented in other countries as standard of care. And right now we still have our mainstream cardiology community not measuring these things. And I mean, and sadly, one of them made the New York Times because the trainer on the on the TV show, the weight loss TV show where he would, literally he has a heart attack at 52 years old, and he's the trainer. He was this fit guy, stacked, looked fantastic, and he has a heart attack. And the New York Times headline was the test that doctors do not measure or don't know about, and it's LP little a. Now, if you guys don't know what that is, you haven't had it tested, that's concerning to me. That should be a public health metric that we do for every individual because it risk stratifies people in a different way. So some of those tests, the lower hanging fruit, so to speak, here, that's not super controversial, that you can look at other countries and look at just go Google it. I mean, it's not that hard, but LP little a is one of them. That's a biomarker. And that's a biomarker that's essentially these what are called lipoproteins. And these are proteins that are kind of signal molecules within the cholesterol little like spherical. Imagine like an oil vinaigrette that is mixed up. It's like how your cholesterol travels in your blood, and it's a marker that puts you at what's called a higher atherogenic or clot producing risk. Okay. Knowing that marker is very important because if it's a certain elevation, we will be more aggressive on everything we do. So that does change it changes what we talk about and what we recommend for you tomorrow. That's a big factor. It also, by the way, we were told, and I was taught this, even after this came out in our longevity and biohacker communities, measure it once, never again. Not what we do. We measure it all the time. I will tell you, fascinating changes that are happening with diet and lifestyle and just things around there. So it is a dynamic marker. It's not going to go to zero, but it will change in measurable states and different things we do, and we can personalize that. The other one is the apoprotein B, ApoB. This kind of is, if you look at other European cardiology societies, it's their standard. They don't even look at total cholesterol, total LDL. Like they might measure, but that's not their standard. That's not their target of therapy. ApoB represents that similar marker on your what's called the higher risk particles, and you want that count to be at a certain level. Now, that count, by the way, that number, your target, is going to vary for individuals. And I say that because we vary their target based on an assimilation of your personal family risk, your genetic findings, your clearly steady results, right? And your lifestyle. Are you carnivore? Are you keto? Are you vegan, vegetarian? And all those things play into our guidance. And they shouldn't be an algorithm. It shouldn't be like everyone should be at 90 or at 80 or at 50. There needs to be numbers that kind of correlate this. So those are one of the more standard ones that are out there that I think people might have heard of. They probably have maybe had them measured. The ones that we talked about that are a little bit less commonly measured, but very impactful.
Let me actually ask you a question real quick, because I think people are probably wondering this. If you've been following along, Peter, I don't know if Huberman's ever talked about this, but if you've been following the health influencer space, if you will, right, it seems that apolipoprotein B has been the main thing for the last 7 or so years. Would you say that the higher ROI test to get and look at now is apolipoprotein A? Would you say that's the case?
Get ApoA as well?
Yeah, would you say that ApoA is a little bit more of a valuable tool than B at this point?
LP little a.
Excuse me, LP little a. Yes.
Yeah, LP little a. So it's 100%. I mean, in terms of like when someone is elevated, it changes everything. Whereas ApoB is much more nuanced. And I think that there's a lot of more argument around what ApoB targets should be, and you don't have a lot of disagreement across the board. Whereas it's really hard to argue that LP little a elevation is a safe factor that should be ignored. But the problem with that is that it's only around what I've seen and what the evidence out there is. I think it's around like 20% of the population has an elevated LP little a. So yeah, I mean, to your point, everyone should know that number at least once. If you've measured it and it's less, it's like many people have, it's a genetically derived thing for sure. There's a genetic risk. And so families that have it, guarantee you, test your kids, you'll know if they have it or not, because it'll be in one of them, through that genetic connection. But if it's less than 10, kind of like that low, you don't ever have to measure it again. That's not going to really change. It's the ones that are like 20 to 50, 50 to 80, 80 to 100. Those we've seen dynamic shifts. When you go over 300, I mean, it is such a high incidence of disease. It's absolutely game changer. So to your point, I mean, it is so important that you have it checked at least once. And if you're in that gray zone, mid zone, regularly. If you're high, I mean, yes, regularly. But if it's low, you can stop if it's low.
Great. All right. Do you go through the rest of the ones that people should ask for? You were about to go through some more.
Yeah, so the other ones, and these are ones that are a little bit more nuanced, but they have evidence base behind their value. And so I bring that up because these are not like oh, I partnered with this fun group that's measuring this like one-off test, like, and which is exciting place in science to be too, but that's not what these are. Like these are measured by place, like the Boston Heart Lab and the Cleveland Heart Lab. Like these are not like experimental, put it say. But when you look at what their overall picture is, they're looking at inflammation. So everyone's heard of inflammation. You can't say inflammation is good or bad because inflammation is part of our body's response to the world. It's how we defend cancer. It's how we adapt from muscles from after a workout. It's how we get stronger, right? But it's also how we hurt ourselves. I mean, inflammation gone awry comes from the world that when we used to work together in the hospital of sepsis and the body attacking itself through too much inflammation. So it's not a good or a bad thing. It's a thing. And in certain scenarios we want it, in some scenarios we don't. In heart disease, inflammation is the linchpin that causes the process to happen in the first place. Without inflammation, it wouldn't happen. You can have the cholesterol.
This was a radical idea about 10 years ago, right? But this is how we're beginning to understand many, many diseases, but especially heart disease.
Yeah, and this is why if you've looked at your own labs, this is kind of a fun thing I have people go through. Read your HSCRP, which most doctors are starting to measure with individuals. And that's called high sensitivity C-reactive protein, or CRP. C-reactive protein is the name of a protein that kind of gets turned on during inflammation. So you would never, I mean, we've had this done accidentally with our patients where someone got sick and didn't know they shouldn't measure that. But like if you measure during sickness, like the flu, it's going to be like 20, which is what it's supposed to be.
As it should be.
Because your body's sick, right? Like it's fighting. And so I don't want to measure your long-term risk of inflammation when acutely you should be inflamed. Similarly, when people have had blood work with us, I say, don't do like high intensity workouts 48 hours before. Why? Well, because of that same reason, because the inflammation is like, you just did a HIIT workout at Barry's boot camp. I gotta fix your muscles. Well, yeah, you're gonna be inflamed for 24 hours, but not for your life, right? So, but HSCRP is the the early marker. If you read under the lab report from Quest, from LabCorp, from anyone, right? It's going to say, below 1 is the lowest risk for cardiac disease. 1.0 to 3.0 or 2.9, whatever, is moderate risk. Above 3.0, high risk. So there's on your labs right now your risk of heart disease connected to an inflammatory marker. Right. And they don't even put that marker on the cholesterol, by the way. They don't even say heart disease risk. They just put the cholesterol high or low, but it's a very clear connection. So now the rest of these markers are in that space, but remember, we just talked about HSCRP goes up with, infection. These other markers, some of them are so sensitive, they only go up and they measure active plaque being laid down. They measure active disease. And so it's and vascular inflammation or blood vessel inflammation specifically, not whole body inflammation. So there's some nuance there and it's exciting. So what these represent, so kind of on the spectrum of these, one of them is LPPLA2. And this lipoprotein, you kind of keep coming back to lipoproteins, signal molecules, right? So this is an inflammatory molecule that oxidizes our LDL particles. And what oxidation just means, think of it like, how copper turns green in exposure to air, right? That's oxidation. Oxidation is the rust in your car. For those of us that you're near the coast and you live there, you're going to get this like rust in your metal, right? That's just from oxidation. That happens in our blood vessels. Not good.
We don't want it.
Right. And so oxidized LDL, OXLDL, is another test. And that's actually a direct measure of that. So now you're measuring the enzyme, the lipoprotein that signals it, and then the actual downstream thing itself. And again,
here we are transitioning from, are you old and do you smoke? You might be at risk from heart disease, to, is that physiological process currently happening right here, right now? Right. Dramatically different way to assess the situation.
And we'll get into this, but not only that, is it abnormal right now? And then now like you're scared. I told you it's elevated. You have this risk and you're like, well, what do I do? And you do some things and then not in 6 months, I'll see you later. It's like next month,
Yeah.
spend the money, test it again, and guess what?
Yep.
Your lifestyle changes, you made it better. So now in 1 month, you lowered your heart disease risk, not 6 months with a statin. Okay. Like that's
Totally.
wild. No one's ever taught us that. So that's kind of where that's again, our goal here is empowering you to know what you can do to help your life out without having to be stuck on a pharmaceutical, if possible, right? And I'm not saying pharmaceuticals are bad all the time. That's not the message here. It's just, please understand the message really is about knowing where you can pull levers to help yourself out. So on that, to finish out those tests, the other one is myeloperoxidase. Myeloperoxidase comes from our white blood cells, leukocytes, white blood cells, and it stimulates that oxidative stress. We just talked about oxidation that damages the LDL. So here it is, another measure of that. It also, if you guys have heard of the nitric oxide is, you remember with nitrous gases when people think of an anesthesia. This is similar, but not the same this is made by our blood vessels. It's released for healthy relaxation of the blood vessel. So nitric oxide dilates it, and imagine exhaling is kind of a relaxation. So when you have these elevated inflammation markers, that inhibits that. Think about why. Like, it's inflamed, they're tight, they want to bring things in, they don't want to relax, right? Think of it as fight or flight, similar. So that's a bad scenario there. And then the other one that we look at in that space that's related to that is the ADMA, SDMA. And those are, they just stand for the dimethylarginine, which is a marker of, it's one of the amino acids, but essentially these are asymmetric and symmetric measurements of those things. And these things directly inhibit nitric oxide. So all you have to know about that is that in this panel, and we have this panel, by the way, on our full script site. You guys can take a look at it, but it's labeled out there for you. You can go look these up, Google them all what you want, and read about them.
I'll put this in the show notes as well.
Okay. But the ADMA, SDMA, they're a direct measurement of inhibition of that nitric oxide. So if your blood pressure is elevated, by the way, you have hypertension, and your doctor's like, oh, here's your, labetalol or melodipine, or here's your blood pressure medicine, and you ask them this question: when do I get off this? They're like, you don't. Like, this is welcome to the rest of your life. And what we're going to push you on, what Dr. Maloney and I will tell you is like, okay, here's what we're going to start you on, but we're going to fix that. We're going to get you off that. How we're going to do that, that's another discussion. But so ADMA, SDMA is another one of those. And that is, it's part of that process of like that going down to like what are the causes of this. It's that nitric oxide production. And the last one is the fibrinogen. Fibrinogen is a direct measure of actual fibrin, which is part of the blood clotting, that soft plaque we talked about. Like, is this activity, the fibrinogen activity, is it elevated? Am I laying down clot? Is this happening right now? So these are factors that are very important for us to look at this, elements of the active process that's happening right now. And the last one, just to finish this off, is called the F2 isoprostane. And this is another measurement of that kind of oxidative stress being happening. So these are listed out, and these are nuanced, we'll call them upstream markers of the active process of inflammation and response of the body that can be damaging you and starting to contribute to heart disease.
Fantastic. And it's moving away from population level health and taking that and throwing it on a really dynamic individual. And it's moving towards getting the best picture of what's actually going on inside your body right now. And again, we'll throw all those in the show notes, because not everyone, we're not going to see everybody who's listening to this, but we want them to be able to talk to their doctor and get these tests done so they can know what's going on best with them. And by the way, a quick note on that. Your doctor, a lot of times, like you said, they're going to tell you, oh, I'm not going to order that because it's not going to change what I do. It's a tough conversation to have with them, but you got to understand that doctors are trained on this concept of conserving resources and practicing evidence-based or population-based health, right? And so a lot of times they don't want to order things because you're taught not to waste resources. You're not wasting resources, guys. There's tons of lab companies out here that are pining to do these tests. You're not taking somebody else's slot for a life-saving procedure. That's not what's going on here. In fact, this is saving and freeing up more slots for cardiac catheterizations to happen, where they actually go inside the blood vessels. And this is the next best way to see what's actually going on with your heart, freeing up those spots. Ask your doctor about this. Don't be afraid to push.
And
Let's
I'll add one thing that you just said there about, which is interesting, and it just kind of hit me that there's a very big difference between, and by the way, we will give you in the show notes here, if you know, there's an amazing amount of resources that are evidence-based supporting what we just talked about, these markers and their importance and their value and the mechanistic side of it. So it's not that they're not evidence-based, but more to your point, like they are not, society recommended. They're not population-based. They're not recommended by the
insurance
honestly, the
companies.
insurance companies.
Yeah.
And if you ask your insurance company to pay for any of these things, I can almost hear their laughter over the phone. They don't want to pay for things that are regular and normal accepted. These nuanced things, there's no chance. So this is where we're advocating for you to advocate for you, right? Learning what you, and honestly figuring out, what you want to pay for in your health, and invest in, because these are things that will be cash based. Now, to your point, Dr. Maloney, yes, these things are getting much easier to get, and they don't have to be, like run through insurance and run through one provider. There are many people that can get these reasonably available and stuff. So,
And let's do a segment on that at the end, by the way. We'll do a segment on that, of just kind of like you have $500 to spend, right?
yeah,
How should you do it, right?
yeah.
Okay, so we used to risk stratify by age, smoking, all that. We've moved way beyond that. We look at your family history, we look at your age, all that stuff, and we do targeted blood work to assess, whether or not these biological processes around your heart may or may not be happening. Then we send you for imaging, which gives us a much better idea. We talked about the coronary calcium scan, the Cleerly test, which you talked about. What else? What else is out there from an imaging and function assessing how well the heart is actually working right now standpoint? What
So
else is out there?
yeah, and this is our like, to me, this is the most exciting part of the practice now. And this is something that Dr. Maloney, you and I are working now with our colleagues over at Superform on the performance side of things. And this is where we take the heart, and we just talked about structure and some mechanisms, some markers, but function. And this is lacking in everything in medicine. And think, right now, you will not get insurance to approve a functional test, which is a stress test. Okay, put the heart through some work without presence of symptoms or known disease. So if they've established you have a stent in place and you have heart disease, or you've had chest pain that they're worried about heart etiology, you might get it approved for a cardiology to do a stress test. I'm not taking away from the need there, but that's just very late. So we're
Exactly.
talking
It's
about,
just more of the whole medical system, from insurance to pharma to, I'm sorry, but oftentimes your actual doctor is going to wait until you're having a heart attack and you're not getting proper oxygen delivery to your heart to actually look further. Sorry, continue.
correct, yeah. And so this is now where we push, and part of our assessment for an individual, the comprehensive assessment that we truly know you and your risk, is pushing that heart to function. So it's the analogy of like x-raying your ankle but watching you walk. There's no physician that can look at an x-ray of an ankle and predict if that patient can walk. I mean, yes, if it's grossly fractured, sure, but a massive sprain can look perfect on an x-ray and be impossible to ambulate for the next couple days. So pushing you through the metrics of high intensity training and watching your heart at its extreme is something that is absent in medicine today. We think of it in performance space. You've heard of athletes that do this. You might hear of like the, special people that are really into this. Like, we have the mindset that I want to know what every individual's heart can do, because until you push it through that, right, you don't know what's capable. And all you have to look no further. And when Dr. Maloney and I first started working together in Philadelphia, every first snow would be heart attack season. Why is that? Well, individuals that have not been working out, have not moved themselves for who knows how long, are now forced to go shovel their driveway. And that is it. If you haven't shoveled a driveway, I'm a West Coast guy. When I was out there in the East Coast, I couldn't believe how hard that was. That's like doing, burpees and squats and lifts all at once. It's an insane workout. But this is why we saw them come into the hospital with their acute MIs, with their acute heart attacks, because they have never put themselves through that test before.
Absolutely.
I mean, so now concepts you guys heard about measure like VO2 max, and everyone's like, I don't want to do that. And let me be frank, I don't either. It's
Yeah.
uncomfortable to fail and to push you where, and think about a stress test compared to VO2 max has two important distinctions. We are not putting you to we're not measuring you on a stress test towards your metric of performance. It's just towards a resistance training. Like how fast are you going on what incline? But it's not
And let
looking at,
me and let
yeah.
me let me touch on that because which we will eventually get into on this show in the future. Like I have had my a whole gamut of health issues myself, including heart issues. An exercise stress test is seeing if when you work out just a little bit, if you have a massive heart attack. That's it. That's all it is. It sounds super fancy, right? It sounds really advanced. Sounds like you're going to glean a lot of valuable information about your heart and your own health that you can use to get healthier. That's not what it is. You can imagine that the way more informative and useful test or outcome of doing this testing would be how well is my heart functioning, like compared to other people my age, other people with my level of physical activity, et cetera, et cetera. It's actually getting a detailed report on the function, not just whether or not you are screwed.
Right. I mean, it's such an eloquent point that I think we gonna we gloss over because I've had patients and here part of my goal, like when we talk about this, is really get the message across to patients that like if you've had a stress test and you have the cardiologist saying you're good, what they're saying is to your point, you're not having a heart attack.
That's
That
all.
that's very
That's
different than
all.
you're good. That just
Yeah.
means great. You're not actually like dying of a heart attack right now, and that's a very different thing. And also, just to be clear, the when they put you on the treadmill, and I've had many. If you guys have had these before, love to hear about it. But we have so many stories of our athletic patients, right? More higher performance individuals that go through a stress test for various reasons, screening, or they had some weird blip and they were concerned. And they're like, I wasn't even worked out because they're so used to pushing themselves to a high level that the stress test is like, can you get to this population-based workload standard, not performance-based standard, not a unique you standard. So if it's a workload, that's just like how fast you're going, the speed on the treadmill and the elevation. That's it. They're not looking at your heart rate. So imagine like, I was joking like these amazing, marathon runners or cyclists like Tadej Pogacar, who's just won this Tour de France and probably one of the fastest cyclists in the world ever. And this guy, if he's on the same incline, right, doing the same workload, and him and you look at our heart rates, very different story. Now, did we do the same? Is it the same test of ability? No, that VO2 max, you've heard of VO2 max. This is a direct measure of you, how you respond, and it's the gold standard for really cardiorespiratory fitness, which is why you've heard of it being a predictor for mortality, longevity, because it's an ultimate measure of like performance, much more than just looking for disease.
Absolutely. It's concerning. I think a lot of people don't realize this, but the standard of care is like anti-personalized medicine. They don't want to look at just you, right? They want to see where you fit in within the broader population-based bell curve. And we all know that we're we're all unique in our own ways. And so it just doesn't really make sense. So walk through the VO2 real quick for someone who's never even heard of this.
So the VO2 max test is a stepwise increased, load put on you, whether you're on a treadmill, like a walking treadmill or a stationary bike. But we are put a mask on you, and we are measuring the exchange of gases from oxygen and carbon dioxide that you are breathing in and out, and measuring your heart rate. So we're seeing this, kind of the effort and trending that, and more of the advanced places like ours will measure lactate with you, and that's going to measure like kind of like your cellular ability to kind of get rid of these toxins as well as use it as a fuel. So lactate metabolism actually changes with fitness, and that's part of the story. And the VO2 max is then stepwise measuring those oxygen gas exchanges, and as we increase your workload, your consumption of oxygen goes up, and then that ratio changes, and we're pushing you through the entire time, and you go until you fail. Now think about that. There is no stopping. Like we don't stop you at a point where it's like this threshold at this number. We see you at that level of you can't go anymore. And think about the last time you've done that to yourself in a workout. So people that have not done this, like it's a very different feeling to literally be like, I have nothing left. I
Dramatically
won't
different.
feel. They're dramatically different. And so, but imagine that's pushing the heart to a very extreme degree. So those screening tests that we do that kind of get us there are very important for us to have the individual understand, like that depth of their fitness on a level they've never seen before. And then that can be reported and put into an age bracket that is showing you like, good, better, elite, superior. And then you'll also get to compare that to, we'll show you what a pro does.
And also compare it to yourself 2 to 3 months from now when you make all of these interventional
Absolutely.
changes.
And then guiding you on how to train towards it. So if it is low and you're impaired there because you don't work it out, that's okay, but let's work you there. And so, and we've been measuring this now on young athletes in their 20s and 30s, and you'd be amazed. Like you could be, the strongest guy in the gym and your VO2 max can be subpar, like not even average, because you didn't train that system. It's okay, but if you want to be that kind of, that like overall athlete, overall kind of fitness, optimizer, you're going to hit many different levers. That's one of the levers we're going to push you on. So, but this for the cardiac risk patient, when I say risk, like every one of us has a heart, and every one of us is at risk for this process. So
Overwhelming odds are, no matter who you are, that heart disease will be the thing you'll get that'll impact your health the most later in life.
Correct. So,
Yeah.
so why not know that at a time where you can do something about it? And by the way, is there an age that we don't do VO2 max? The answer is no. We risk stratify them and give them insights on that. But they've measured these in people at every decade of life, and that means the 80s and 90s has been measured. So, and there's a lot of I think risk aversion to that space, especially in America, with a lot of our unfortunate medical liability approaches that other countries don't have, are similar processes. And so you have a lot that guides a lot of the decisions that doctors give patients, and telling patients to, not lift weights because they're frail, or not push their heart because they don't want to have a heart attack. And it's like, meanwhile, that's the thing that saves you. So this is kind of, and to me, it is almost the most important part of this assessment, because function is the ultimate thing that matters. Like if you go up a staircase and you're out of breath and you have a little bit of chest tightness, like I don't care if you're 20, 40, or 90, that's not good. And so
Exactly.
we need to deep dive and understand that.
Exactly. Let's talk about some misconceptions, because we've been kind of hitting that along the way. I would say number one, your cholesterol is not the end all be all risk factor for determining whether or not you're at risk of heart disease that you think it is, and hopefully that your doctor doesn't think it is. Another one I want to tell people is I do a lot of urgent care work, and I see a lot of people coming in with chest pain, with concerns for their heart. We always do an EKG. Why don't you talk about the EKG's diagnostic utility? I think most people would feel really relieved if they had an EKG done and it was normal. I think by now everyone can kind of infer that the diagnostic utility is not all that great. Why don't you touch on that? Because I think it's something that people are probably wondering.
Yeah, I mean, and again, it's an important piece of the diagnostic, pathway, and it tells us unique information. It looks at the electronic signals through the heart, and so we use it to assess. And many of you have been through ERs or urgent cares with shortness of breath or chest pain, and you had an EKG done, and they're like, "You're all good. It's not your heart." I mean, it's a bold
And
thing.
what they're really saying there, and again, you guys will really notice this trend. They're saying you're not having a massive heart attack right now.
Correct. Right. And
That's
so the subtleties of those changes, of the electronic changes, if you're having active processes and there is abnormality there, we are at a different stage now. We have established disease that's translating to you having heart potential damage. And then we get certain blood tests that are not tests we talk about today, like troponin. You might have heard of troponin or BNP. These are separate tests that are looking for actual heart damage stretch that's happening right then. Okay, separate thing. The EKG or ECG, electrocardiogram, is just a signal of like what the heart is looking like right now. And if there is a scar, like an old injury, like a previous heart attack that was subtle that maybe you didn't know about, that happens, it might show some signal there. So we might see that abnormality there. Is also a good tool for testing for arrhythmias. Again, it's a 5-second view of your body. So it's kind of like when your car makes a noise and you go to the mechanic and it doesn't make the noise anymore. You're like, I don't know. It was just making noise down the road. So if we don't capture in that 5 seconds, your arrhythmia, then we say you don't have one. Meanwhile, you just had one 5 minutes before and 5 minutes after, but we didn't capture it. And people have known that frustration as well. So that's why we do these home monitors are like 2 weeks, every heartbeat, different story. But again, your question, what does it tell people? Is there an active process? Was there a remote process that was pretty severe? And that's all it tells you. It does not give any insight into the presence of heart disease. So let me say it again. It gives zero insight that you have or do not have heart disease. In fact, one of my patients, and he's gonna see this discussion, so he'll know who he is, but wonderful guy, and I love him. And he had one of the most sad, tragic experiences. And luckily he's doing amazing today, but he had a full-blown cardiac arrest, heart attack, where his EKG 1 hour prior was perfectly normal. And he had the arrest in the ER. So all these things are beneficial why he's alive today. But just understand the test fails many times, and that's not its goal. And there's things that we call sensitivity, specificity. We don't have to get into statistics right now, but essentially, if it's abnormal, it's valuable. Just understand that. If it's normal, great, but don't be like, oh, woohoo, I'm great. just put that in the category of like, okay, it's normal, but I'm not gonna, stop worrying about my heart. That's not the goal.
Exactly. An EKG, just like many other of the traditional tests, are good at determining whether or not you are currently in just the highest degree of trouble. So going back to the car, an EKG is telling you whether or not the car can't start, whether all the tires are blown out, right? Fine. This test is not to be used to risk stratify people for heart disease.
Right. Right. And we'll do it regularly, and we should do it annually. And we're a fan of it. We're just like, we're not going to put the stock that you often get told, which is like, okay. And a lot of times what you'll hear is there's this stepwise approach. And the stepwise approach is like, we're going to do this test. If it's abnormal, we'll do this test. And if that's abnormal, we do this test. Now, that mentality is an actuarial or a financial basement, decision process. Okay. So when you're talking about population medicine, you're like, we can't afford to do this test on everybody. So we're going to recommend it on the highest risk individuals. Great. So that's why, just understand, that's why the algorithm exists the way it does. When you're taking care of you and you're only worried about you, you're not worried about the population. You're worried about you. So we're just going to empower you to understand, do not think of stepwise, think of, comprehensive.
Yeah. And on that note, there's just many evidence and population-based recommendations that are not going to track for you individually. If 10 people in your family have had heart attacks at the age of 35 and you're 33 with normal cholesterol, you should get more advanced testing done. Right. And this sounds crazy, guys. Maybe it doesn't sound crazy to most people, but you will go to 10 cardiologists. 9 out of 10 of them might tell you there's nothing to do. Unfortunately, we live in this landscape right now where if you want personalized precision medicine, you got to find people that explicitly say they want to provide that, or more commonly, you need to advocate for yourself. And that is the goal of what we're doing here, is we want to help people be able to more effectively advocate for themselves.
Yeah. And I think something that you just prompted this idea, and we'll share that piece you and I were working on the recent study. But one of the misconceptions, and I think this is something that can affect you, whoever hears this tomorrow morning, of how to understand your risks. And you just heard us talk a lot about function. So think of that as fitness. The function is fitness. Fitness is like the ability to kind of move through the world in this way and perform. And the question you're going to ask is like, oh, well, I've looked at people that I know that are overweight or they look a certain way and they must be unfit because of their size. There's what I've realized has been humbled me in this space of moving from reactive to proactive and longevity space medicine is that you can never predict an individual's fitness by their body habitus. Yes, there are trends, but you'd be surprised. And there's a study that supports this. And so we have a Substack posting about this on fit versus fat. And I'm going to say that I know there's a big movement right now with all the GLPs and the benefits that they've had there, and there's a separate discussion there. But that's it. That, that in that scenario, the goal is to get thin, as if that's the definition of fitness. And I'll just advocate and say that has nothing to do with fitness. And so when they've tested individuals who were all different levels of size, from normal weight, overweight, and then obese, and then they stratified them by fitness, suddenly the fit obese individual, okay, fit and obese, not overweight, obese, had a lower mortality risk than the thin, unfit individual. So let that sink in. Thin guy, not fit. Obese guy, fit. This guy lives. That's the bottom line. So this is a 400,000 patient study that was done. So understand that the science here is strong. It's why we advocate for this. It's why we'll never stop pushing for it. It's why some patients have left our practice, because they just want to hear what medicine or supplement do I take? And there's a ceiling of what those things can do. There's a ceiling. And if you are not moving the body, if you are not pushing yourself, it's unfortunate you can't gain the gains you want. And so we will always advocate for that. We'll talk about that. The science is pretty compelling, but that's a misconception out there. And so that's why I'm saying tomorrow morning, fitness can start to improve, and there's personalized guidance around that, but it can be moving tomorrow.
And it starts with the assessment. This whole episode has really been about tests you can do for your heart, right? We'll definitely talk at some point about more targeted interventions, but just remember, the intervention is only as good as the assessment. Well, I think we covered most of everything. We're gonna do many more episodes of this. We'll start by kind of covering the biggest risks to your health, and try to take a Q&A approach the whole time. Definitely going to keep an eye out for any comments. Feel free to ask us anything. We'll try to get back to you in the comments, and we'll definitely take all that into consideration when we do the next episode.
Yeah. And just, I think our ultimate goal here really is to inform, right? To arm, not alarm, right? It's this idea of I want you understanding that when we tell you these things, it's because we believe and have shown in our own patients that you can move these needles, that you can change your life. Then we put the power in you to decide what do you want to do? What do you want? How do you want to live? And what do you want to, are you willing to change in your life to make these metrics? And that way you feel less almost dependent on the system and more empowered on yourself to say, I can make this change and measure it and watch it get better and watch my health improve. And then just be like, oh my gosh. And so for us, our goal is to see patients who never need us, right? Who don't come to us for reactive therapies, but come to us because they are empowered to stay ahead of the game and be like, hey, how are my numbers looking? Where am I tracking? How's my risk assessments? I've done these changes. What do I need to do? I mean, and there's many partners in this space that we're excited working with, that we can, kind of connect you with those spaces. But yeah, that's for those that stayed with us this long, we should offer them some kind of Easter egg. We made it 58 minutes in.
Here's the reward, and here's the Easter egg. In 1 minute or less, you're talking to a friend. He's 40 years old, he's pretty fit, but his dad had heart disease in his 60s, and he's taking control of his health. He wants to know what tests he should get done in order to make sure everything is okay with his heart.
Genetics, CT angiography for soft plaque, that's the Cleerly study that we ordered. An advanced lipid biomarker test that includes ApoB, Lp(a), like we discussed. The advanced inflammation marker with the markers we went through, and we can list them all out. And find someone that will put you through through the metrics of a VO2 max physiologic testing. EKG, echocardiography are things we didn't talk too much about. We talked about the EKG today, echocardiograms are ultrasounds of the heart, structural things. We kind of see that structure on the CAT scan. So those things are possible, but I think those 5 right there, I would hit those. And understand, hit those annually. You're not done. You're not done at 40, because it's we need this regularly.
Indeed. What genetic tests should they have done? Because I don't think we covered that.
There are multiple genetic panels that help us understand how someone processes certain things. And so, everyone's heard of the ApoE gene they call it the Alzheimer's gene. It's much more complicated than that, but that helps us understand that changes your body's metabolism risks for blood sugar regulation, actually, and you'll see impacts there on what diet you should look at. There are also markers for LDL metabolism and some oxidative stress markers. So there are certain genes, we won't go into all the depth of them, but we have different models of partners that work with us in this space to understand those disease modifying agents that could be helpful and insightful, just so an individual knows, is this, for example, there are familial conditions that someone can't get their LDL down, their cholesterol down, their ApoB down without medication, because they have a genetic predisposition just to make cholesterol just through the roof. And they're usually people, honestly, sadly, are having processes happening, heart attacks and stuff, in their 20s and 30s. So it's usually declares itself more. But again, those are why we measure these things, is to get just to understand the context of you and what we need to kind of consider. So
Awesome. Well, this was great. Hopefully people found it useful. That's a wrap. See you guys next time.
awesome.